Hello, my name is David Koenig and I'm a general practitioner with a special interest in headache working out of Exeter. I want to just put together some thoughts to support parents who have children who have problems with headache and in particular migraine. My remarks are directed at children really between the ages of 10 and 16. After 16 they become really young adults, but they're equally applicable to the age group right across between 5 and 18. I've been very fortunate. I work in Exeter, which is a very nice part of the country in the southwest, and I run the Exeter Headache Clinic for the NHS. We take referrals from GP colleagues who find headache difficult to manage and for difficult cases. And I've been involved with headache now for over 20 years. I was previously the Royal College of General Practitioners Headache Champion and have been involved with the British Association for the Study of Headache for a long time. And my role really has been to try and improve the quality and standards of headache management in general practice. This is our headache clinic website you might like to have a look at. There's lots of videos here for doctors and both patients, lots of management guidance, guidelines, patient information sheets. You may be particularly interested to look at this one on managing headache in children. If your GP is struggling, then you may like to give him or her a copy of that printout, but all sorts of useful stuff there you may like to have a little look at. So what I'd like to do is just briefly overview what's happening out there in the community, a little bit about what causes migraine, where does it come from, and then finish off with how can we actually manage it and some principles for treating and guiding our management of migraine. I want to start off by addressing and getting this difficult issue out of the way. Is this something serious? And there's always a concern both for parents, young people and practitioners that there may be something serious going on, and in particular brain tumour is what we're talking about. This is clearly a devastating event, but fortunately treatment has improved quite significantly over the last few years, but it is also quite rare. This is based on some of the work we've done out of our headache clinic. We looked at a big study of over 45,000 new headache presentations in young people. We followed them up for a year, and we can tell you that the risk of an underlying problem with a headache when they present to see the GP is less than 3 in every 10,000 GP new consultations with headache. That's quite a low number, but of those out in the community, those who don't go and see their GP, young people who are struggling with headache out in the community, as less than 10% actually go and see their GP. I think the best estimate we can offer of the possibility of having an underlying problem is in every 100,000 children with headache out there, less than 3 will have an underlying problem. That's a very, very low number from a medical perspective. So what are the things we need to be on the lookout for? And these are some of the worrying features that are associated with headache we may want to look into in a little more detail. We're always worried about headache that is progressive and continuous. We're a little bit concerned about associated problems with the nervous system, fits, faints, visual disturbances, weaknesses, balance problems. These are continual nervous system problems. We're going to pick up the concept of the aura in a few slides' time. So there is often a transient neurological problem with migraine, the migraine process, but these are continuous and progressive neurological problems. Often migraine wakes at night time, but we are a little bit concerned about headaches that persistently wake at night, and also headaches that can be made worse by anything that raises the pressure inside the head, coughing, sneezing, straining, and also headache with behavioural change. It's got a good website. The Headache Smart organisation aims to diagnose underlying problems early, and you may like to have a look at that if you want more information about this area. So having got that out of the way, let's have a look at really what we're talking about here. And there's two types of headache in young people that we recognise. One is attention type headache, and the other is migraine. Attention type headache is common, it's dull, no other features, it's tight like a band round the head. We used to think this was due to tension in the muscles of the neck and the head, but we're not quite sure what's going on here now. Migraine we have a little bit more information about. It's quite a different type of headache. It's pulsatile, it's associated with nausea, often vomiting. And there is this sensitivity to light, sound, touch, movement. The young person wants to go lie down in a darkened room, turn the television down, doesn't like to be touched. This increased sensitivity. And in young people, quite often we see a lot of a mixed picture, tension type overlap with migraine. Now, this is a bit of a complex area, but I think many people, including myself, would see tension type headache as part of a migraine spectrum. If you look hard enough for someone with a tension type headache, ongoing or episodic, you'll find migrainous elements somewhere along that track. And I think it's useful to think of migraine and tension type headache as part of one headache spectrum, particularly in young people. And as the principles of management are broadly similar, I'm going to focus totally on migraine. It's actually very rare that I diagnose tension type headache in my practice. So what is migraine? What are the features of a migraine headache? Well, this is the typical full house of migraine features. Not everyone gets all these features. So the first thing that happens is a pre-headache. We call this a prodrome, where something is happening in the body, the brain is beginning to wind up. Food craving, particular types of food, aches and pains, lethargy, mood changes, yawning, tiredness. These are signs that something is warming up. Then there's the aura. Now the aura occurs in 30% of adults, probably less in young people, 20%, but they can be very frightening. These are neurological presentations of anything really. The aura is caused by a wave of electricity that's sweeping across the surface of the brain, and we can actually measure it. It goes at 3 millimeters a minute, and depending on which part of the brain it's sweeping across gives you the type of aura that you recognize. And the most common type of aura is a visual aura, where the electricity goes across the back of the brain, where the occipital cortex is, where the visual part of the brain is. And this can be flashing lights, it can be central blindness. Other types of aura, pins and needles are the next most common one, but you get anything from difficulty with speech, weakness, balance issues. Auras are always on the move, so your flashing lights are expanding or contracting, your central blindness is expanding, pins and needles are coming up your arm, and that's quite a useful diagnostic feature. And auras last between about 30 and 60 minutes. Auras shouldn't really go on, they can do, but they shouldn't really go on for more than an hour. So auras are not common in children, not as common as adults, but they still can occur, and they can be very frightening for the young person. Then the headache phase builds up. Pulsatile headache can be one or two sides. A lot of people think that if headache is not one-sided, it's not migraine. That's not true. It's usually one-sided, because it can be both. Then the headache resolves, and this resolution takes anything between 1 and 72 hours. In adults, 4 to 72 hours. In young people, particularly young children, the headache phase tends to be quite short. Then you get this post-headache phase. We call this a postdrome. Usually people are lethargic, fatigued, but they can be elated. They might get muscle pain. So that's the whole package, and underpinned by inevitably an element of nausea, if not vomiting. And I think this nausea and vomiting is important from a treatment perspective, in that the stomach is closing down as part of this process. So anything you take by mouth in terms of therapy is not going to get absorbed well into the system. So migraine is more than just a headache. It's a whole package of disturbances of the central nervous system. When do young people get headache? Well, this graph shows the incidence of headache, and here we can see the number of people in every 1,000 number of children per age group that are getting migraine. And boys kick in earlier than girls, and you can see that even as young as 5, there's a significant number of people getting migraine. Girls, the maximum age of incidence in girls is around the age of 14, 15 with the onset of menstruation. Then after that time, the prevalence of migraine in females is much higher than in males. So although you can get migraine developing at any age in life, most of the migraine starts kicking off during the mid-teens, an area which there are already quite considerable demands on these young people. This is a busy slide. I'll just talk you through it. It shows the global burden of different diseases in 2019 between the ages of 10 and 24. So here are all the leading causes of disability across the world. I won't go into how this is actually measured, but it's interesting to note that headache disorders are actually second in the world. So they have a significant impact upon people. This is the increase in disability since 1990, and you can see that headache disorders have increased by 25%. I don't think this is because headache is any more common than it used to be. I think this is just because we're actually diagnosing it slightly better. But this really makes the point that there is a considerable burden of headache disorders, and the majority of these headache disorders, in fact virtually all of it, will be migraine. So what's happening out there in the community? Well, these are based on some of the studies we've done out of the headache clinic, and a lot of the information I'll be giving you is based on studies we've done, and if you're not familiar with it, these are the references to the studies which I'll put in at the end of this talk. So we looked at just over 1,000 young people in our local school and asked them, do you have headache that impacts upon the quality of life? And interestingly, we were quite surprised by 20% of our young people, this was between the ages of 11 and 16 in this particular case, had an impact of headache. 10% of these children had a significant impact. Nevertheless, less than 10% visited their GP. And when they went to see their GP in primary care, 25% were referred. This is a high referral rate, really reflecting the fact that general practice GPs are not very confident about dealing with headache in children. Just to compare that with what's happening in adults, we did a similar study with adults. Again, this figure of 20% is coming through. 50% visit their GP. So although this GP visitation seeking help is greater, it's still quite low, less than 50%, in fact just under. And GPs refer 3% onto their consultant colleagues in hospital. So it's a picture of high impact, but not actually seeking help. Just to make the point that this problem is also going on as they go into adulthood, so it's really important to get hold of things soon. Just to make the point that of young people, a third will get better, a third will stay the same, and a third will get worse. So it is important to get control over the headache early. I often say to people there is no cure at the moment, but the important thing is to shift the locus of control so you're in charge of the headache, you know what's going on, you're in control of it, rather than the headache is in control of you. This gives you a good start in life, and it reduces the impact of your migraine as you get older. So this shows that we've still got, this is a big, our practice looks after the University of Exeter, and in 2002 we surveyed over 1,000 consecutive new entrants to the University of Exeter and asked them if they had headache that impacted upon the quality of life. Again, this figure comes through, this 20% figure comes through. 13% had a significant impact, more than 15 days a month. Less than 5% were receiving prescription for them. Of these 21% were receiving prescription medication. So that reflects the fact that very few had actually sought help. I think this is just a useful medical framework to unpack some of the things that are happening, in fact, in any illness. And it's useful to think of it within any medical presentation within three perspectives: the context of the disease, the illness, and the sickness. So what does this all mean? Well, the disease is what's in the textbook, it's what the doctor diagnoses, this is the pathology, this is the migraine. But migraine is far more than a headache. There's all sorts of things that it comes with. It impacts upon all social and psychological aspects of life. So the illness looks at the broader impact, what the person with the illness, with the disease, recognises. So in migraine, there's often associated anxiety and depression, lots of stress. There can be impact at school, impact at home. So the illness is a much broader perspective on how the disease impacts upon that individual. And there's the sickness, which is how the disease is perceived by society and how society expects the person with that disease to behave. And migraine very much has been stigmatized over the years for a number of reasons, but I think probably the most significant reason is we don't like things that we can't measure, that we can't put a handle on, that we can't give a value to, that we can't take an x-ray of. And brain problems fall very much into this category, and I think migraine has been largely stigmatized because of that. Let's just have a think about what's actually causing migraine, and what we're recognizing there is there's a migraine engine or a migraine generator at the base of the brain, and this is the area that really fires off this whole process that I demonstrated earlier. Now, we've all got this migraine generator. It's just that some have got a lower threshold for it to be firing off, others have got a higher threshold to be firing off. So fortunately, I don't get migraine. I will still have a migraine generator that can be stimulated given suitable circumstances, but my threshold is significantly high enough for it not to be a problem in most day-to-day circumstances. People with a lower threshold have a lower threshold due to a genetic predisposition. And if there's someone in the family, a first degree relative, you have a 70 to 80% chance of having migraine in an offspring due to this genetic predisposition. Now, we're not quite sure how this genetic predisposition is working. In some diseases, for example, cystic fibrosis, an abnormality in one gene will cause the disease. In migraine, there are a number of genes that have been identified that impact upon the threshold of this migraine engine. And these are also interacting with environmental and lifestyle factors. So it's a complex interaction of multiple genes and environmental and lifestyle impact that leads to what the threshold of this migraine engine will be. The other problem, of course, is in young people. Things are changing extremely rapidly. So environmental change is occurring frequently, and also lifestyle, what's happening in their lives, individual lives, is happening very rapidly. So they've got huge challenges to this whole system. So what about the illness, the broader psychology and sociology of the migraine problem? Well, I tried to put together, this is a bit of a complex slide, but this shows, this is a flow diagram I put together some time ago now of how some of these important things are interacting. So it's certainly not just a headache. There's lots of other things going on with people with migraine. So there's lots of psychological problems, increased anxiety and depression. I think this is due to two reasons. First of all, there's, I think, probably almost certainly a genetic underlying crossover for some biochemical reasons. Migraine and depression may have similar biochemical mechanisms, but clearly if you're getting more and more migraine, you're getting increasingly anxious and depressed, which is leading to more migraines. There's a complex interrelationship between these two things going on. And there's all sorts of problems with school. Headache leads to anxiety, depression. They both lead to school absence, and that leads to bullying, poor school performance, sleep disorders, which leads to more headache and more anxiety. People with migraine also get associated tummy problems. This is probably due to problems with modification of pain signals as they get up through the brain. So we see quite a lot of tummy pain, particularly in younger people with migraine. And in fact, there has been a suggestion recently that colic in babies is part of a migrainous type process, although that's still to be resolved. So there's all sorts of complex things going on that lead to the illness, what the person with migraine experiences. And sometimes it's quite difficult to unpack all of this. Just to make the point about depression, this is looking at this big study we had with 45,000 new headaches presenting to their GP. And we also matched these with young people who didn't have a headache. So these people who didn't have a headache had a rate of depression of just under 0.7%. The people with migraine had a rate of depression of twice that. So the increase is certainly twice. In fact, in many studies, it's 3 to 4-fold increase. What about the sickness? Well, I think the sickness reflects the fact that sufferers don't seek help. Migraine is stigmatized. People just think it's only a headache, I'm just going to get on with it. This is an interesting study we did back in 2008. We have a large practice where I work. We have 2,500 children, and we wrote to every child on our practice database saying, look, we have a headache clinic here. We've got an interest in young people. Would you like to come and have a chat to a GP who's got an interest in headaches, see if we can just help you? Interestingly, 3% accepted the invitation. Now we know, because these young people in our practice group area go to the same school where we did our survey, which showed that 20% of children, young people, have a problem. Of these 20%, only 3% accepted an invitation. And these 3% had quite a high impact, 6 days a month, 1 day of school lost. And even when they accepted the invitation, only 66% of that group turned up. So for some reason, people with headache, both adults and young people, don't come forward and seek help. Why might that be? They may not realize they've got a problem. They may not, a lot of people don't realize they've got migraine and things can be done about it. It's only a headache. No one takes it seriously anyway. I think because parents often have had migraine themselves, they don't want to reinforce illness behaviour or even pattern their own health-seeking behaviour. They've had it for years themselves. It's only a headache. There's nothing much that can be done about it. And often they've had poor experience when they've been to see their GP previously. So why bother? There's nothing that can be done. No one takes me seriously. So let's just get on with it. And this really reflects, as another study we did, reflecting that GPs find headache difficult to manage. I won't go into why that is, but I think time is a big thing. GPs only have 10 minutes, and it's very often challenging to unpack a headache in 10 minutes. So in the study we did, only 25% of headaches received a diagnosis when young people presented to their GP. Triptans are one of the mainstays of treatment. Less when migraine was diagnosed, less than 4% actually had a triptan, and many of these people with migraine would benefit from a preventer. Less than 21% had a preventer. So GPs do find it difficult. And this is a study we did again in our local school. It was an interesting study, and it was actually run by young people themselves. Young people undertook the study, and they asked their colleagues to reflect their stories, their narratives about their experience with headache. We call this a qualitative study. These are some of the phrases and remarks that we got back, just to give you a snapshot of what we found. So I haven't asked for help. Headache's not serious, it's just a headache. I don't think anyone can help me. I've had them since I was little. I don't think there's much I can do. They think I put them on. They don't think I get them like I do. Teachers are not sympathetic. They just say, sit quietly, but I can't concentrate. They think you just want to get out of class. So that's really a little snapshot of where we are in the community. People are reluctant to come forward. Needs are invariably not well addressed. So I'm afraid at the moment it's not a good picture, but we can be optimistic in things are getting better. So I hope that's given you a little bit of understanding about where we are, what's going on with migraine. Let's move on now to what we can actually do about it. And as I alluded to earlier, the first thing we have to say is I'm afraid that at the moment there is no cure for migraine. There is unlikely to be a cure for some time. So the focus of attention is understanding what's going on and getting more control over the problem. I think a useful first step is to visit the Migraine Trust website. That's the patient organisation for supporting people with migraine, and there's a very good section there for young people, and I think that's certainly worth a look. When it comes to management within the context of the health service, I just want to bring up a few general points. First of all, a lot of patients and parents quite understandably push for a brain scan. I think an important rule of thumb here is don't investigate unless there's a good reason to do so. Apart from the fact that scans are quite distressing to young people, the main concern is that these scans are now very sensitive, and they can flag up a whole load of incidental abnormalities. These are things that we would have sailed through life quite happily without knowing anything about. Little bits of calcified nodules or little cysts or little vascular abnormalities of the blood vessels. But having seen them there, we don't really know their relevance, what to do about them. And these can cause extreme anxiety. So I think an important rule of thumb is don't go inside the brain unless there's a good reason to do so. And certainly do not image or investigate just for reassurance only. The next step is to avoid triggers and things that change. Now, I think most people with migraine, many adult migraineurs, have spent a lifetime looking for this elusive trigger, this magic bullet that they can avoid, and their whole life will be different. I think certainly some triggers are obvious and some are quite common. Red wine, cheese and chocolate are the most common things cited. But I think an important point to make here is if a trigger is not obvious, don't waste any time looking for it. Certainly don't do any tests for allergies. There's no connection between food allergies and migraine. And don't spend too much time looking for triggers. But I think that the important thing to focus on, I think lots of people don't realise, is that migraineurs have brains that don't respond well to change, both in internal and external environment. So females, when their estrogen changes dramatically prior to menstruation, that can often make migraine a lot worse. Changes in hydration, changes in glucose levels, changes in sleep patterns, changes in stress levels. Often things like changes in atmospheric pressure, changes in humidity. There's not a lot you can do about those, but there are a number of lifestyle things that you can change to make things as constant as possible. And I think this is particularly important in young people. They are particularly sensitive to these changes in their environments, particularly with young people that skip their breakfast, they don't drink enough during the day. So regular meals throughout the day, including snacks to try and keep these glucose levels constant, regular hydration, regular sleep patterns, proper sleep hygiene, which really means no devices in the bedroom. That's a really important point in young people. So keep things as constant as you can. I know that's difficult in today's age, but I think that's a really useful starting point. We have to address any psychological factors. I think all these issues like bullying at school, anxiety, depression are important, so don't be afraid to speak to the school. The government have got this new initiative where they're increasing mental health support in schools, so that might be a useful point to start. Otherwise, you can chat the problem through with your GP and they would be able to signpost you to places where you might be able to address these psychological factors. Anxiety and depression, as I've emphasized, are increasingly frequent with migraine than people without migraine. So finally we come to the pharmaceutical management. What do we actually do medication wise for migraine in young people? Well, there's two approaches here. There's the relievers. We give these when the headache actually occurs, the migraine occurs, and there's the preventers that you take on a daily basis to prevent the migraine from happening. So our mainstay of relievers are paracetamol and ibuprofen, not aspirin in this age group, but you can use paracetamol and ibuprofen. And there is some suggestion that the soluble preparations work a little quicker, they get absorbed a little quicker. One of the things we've got to watch out for here is this condition called medication overuse headache. If you take painkillers on more than 15 days of the month, any type of painkiller, these are going to give you headache due to the painkillers themselves. We don't quite understand what's going on here with underlying mechanism, but they probably sensitize these ascending pain networks that are going up through the brain. So make sure you keep your medication input in painkillers to below 15 days of the month. I think it's always important to take an anti-sickness medication. You have to get this from your GP, but I indicated earlier that part of the migraine process is that the stomach closes down. So anything you take by mouth in terms of painkiller is not going to be absorbed as well as perhaps it should be. So it's important to get an anti-sickness medication on as soon as possible. And with all these relievers, the sooner you treat, the better. This migraine engine is beginning to wind up. It's getting more and more momentum. The stomach is closing down. So the sooner you can identify there's a migraine coming, don't start waiting and thinking, is this going to be a migraine? I'm not quite sure. Get this medication on board. The introduction of the group of drugs known as the triptans have revolutionized the management of migraine. They were introduced in 1990. Sumatriptan, or Imigran is the other name for it, was the first one to be introduced. There are now a number of triptans available. But Sumatriptan nasal spray is licensed for use in young people over the age of 12, and I think this is a useful alternative for young people. It doesn't taste very nice, and you can use Sumatriptan tablets. They're perfectly safe, but they're not licensed, and I'll allude to why that is in a few slides time. They're not licensed for young people. The nasal spray is the only thing that is licensed, but the nasal spray has the advantage that the absorption bypasses the stomach. The absorption is through the lining of the nose, so this does help overcome this nausea problem and this problem with poor absorption. So we move on to the preventers. When should the young person be taking a preventer? Well, there's no hard and fast answer to that. You go by the impact upon quality of life. Lots of people have good control with their relievers. Lots of people have sufficient problem that they need to start thinking about a preventer. No one likes taking medication on a regular basis, but I think it's important to encourage people to take a preventer if they're getting frequent migraine. These are the preventers that we have available to us. I'm not going to go through them in any detail, but I think in my experience Pisotefen works best with young people, particularly the younger age group. The problem is it can gain weight, so you've got to be a little bit careful with that. These are the other things we might like to try. Flunarizine is a useful drug used widely on the continent, but unfortunately it's not licensed in the UK, but it is used in specialist practice. There's lots of new drugs coming on board at the moment. You may have heard of a new group of drugs called CGRP antagonists. This is a very exciting group of drugs. but they are expensive. They're available for adults. They cost about £400 a month, £450 a month. They're not yet haven't been looked at in children, but I think this is something that's on the horizon. That's something we can look forward to. There's no reason why, once the safety studies have been done and the effectiveness studies have been done, they couldn't be used in young people. So this is a bit of a complicated slide, but I just want to make the point about the placebo response, or the dummy drug response in young people. This is why there are a number of problems licensing agents such as these oral triptans. So this shows the response of these various drugs to pyramate and amitriptyline, which we use quite frequently in prevention, response to migraine, against dummy drugs. Now, you may be familiar with this concept of the placebo effect. If we're given a dummy drug for anything, particularly painful problems, there's quite a significant dummy effect. There's lots of intrinsic capacity of the brain itself to heal these processes. And in migraine, in young people, there's a very high placebo rate, and you can see that this is about the same as actually drugs that we use on an active basis, and in fact it's actually better than amitriptyline. And it's the same with triptans, and I think for this reason, because the placebo rate is so high, it's been very difficult getting licensing studies, because to license a drug you have to show a superior effect to placebo, and it's been difficult to do that in young people with a number of the drugs that we use successfully in adults. So that's just an overview of what's going on in young people. I hope it might help you understand a little bit more about your child's problem. Headache in young people is common. They're certainly not alone. It's a global issue. We know that needs are not well addressed, but things are getting better. As I alluded to, it's important to take control early. This doesn't mean to say that your migraine will be better when you're an adult, but the impact upon the quality of your life will certainly be much better. And ultimately, the GP is the first point of contact. There is a lot you can do for your migraine yourself, but if things are not moving forward, it is important to go and see your GP. And if you're not happy with your GP's management, then ask for referral, ideally to a neurologist, pediatric neurologist, or a pediatrician with a special interest, or a GP with a special interest in headache. So I hope that overview has been useful to you and will help you just understand what's going on with a little bit more clarity.